Dr. Gibney is an emergency room physician who is currently a cookie maker. She is board certified and certainly knows how to handle any emergency, but she has now a company called Lucy's Cookies that she has been making cookies for a while, and I'll let her tell you why she makes cookies. But she has been the vice president of our support group for many years and quite the expert to explain to us a little bit more about anaphylaxis. So, Dr. Gibney.
Hi, everyone. So the reason I make cookies is about 10 years old now. My son Colin was diagnosed as an infant with several very severe food allergies. And obviously keeping him safe, being prepared to use epinephrine was important in my family, but then also just living life was important. So an area of challenge for us was finding delicious foods that we knew were safe and had been prepared in appropriate food environment. So it led one thing to the other, and now we're selling cookies all over the United States, Canada, we're in Mexico, and all over the UK. So making lots of cookies each day, probably about 300,000 a day at this point. So it's been really exciting, and I'm happy to answer more questions about that, but that's not what we're here for. So I want to talk a little bit about what is happening in the body during allergic reaction in more depth, going into a couple of the important systems that Dr. Hogan mentioned. Then talk a little bit about epinephrine and how it works. And then we'll get into a couple other points, and of course I'll get back to the topic of food and how food safety plays a role in food allergies. So again, we see the mast cell with the yellow allergen latching on to the mast cell itself, and then what we call degranulation of that mast cell, where the histamine and other chemicals are released. Those circulate through the body, and that's what causes the hives we talked about. It's what causes the GI symptoms. And then where anaphylaxis is concerned, the respiratory system and the cardiovascular system are impacted. And that's where we go into the area of danger with allergic reaction. This slide depicts literally the spectrum of anaphylaxis and spectrum of allergic disease, where you see the arrow coming up and pointing to the orange block, talking about pre-syncope or pre-fainting, laryngeal edema, so vocal cord or throat swelling, and then wheezing is where things really start to be serious. All the way to the far end on the right, we talk about cardiovascular collapse and severe respiratory distress, and that's where we're talking about shock. And people who get that far on the spectrum are in great danger for dying from allergic reaction. So we want to push all the way back to the left, which is usually when we become aware that there might be an allergic reaction in process. The important thing is we do not want to get to orange and the right side of green without giving epinephrine. We want to give epinephrine probably about in the yellow to orange phase, and we'll talk a little bit about why that's so important. So more in depth, thinking about what's happening in the cardiovascular system, it's important to think about what our blood vessels are made of, how they work. So the vessels are tubes, right? And all of our organs are made up of a combination of specialized cells. So those blood vessels are tubes of cells, and they're normally nicely knit together, just like you do knit together your fingers. What happens in anaphylaxis, due to the histamine and the other chemicals, is there's a loosening of that web, and leaking begins. That's why you see the hives that are puffy. You can see other generalized puffiness, or what Dr. Hogan referred to as angioedema. That leaking is occurring, and it becomes dangerous in the cardiovascular system because that tube system is becoming empty. This leads to the heart overworking, so that fast pulse occurs. And if this process goes too far, cardiac arrest can occur because of that increased rate. So this this visual is depicting a normal scenario where there's a nice tight mesh here. This one's talking about a small amount of fluid can come and go, which is normal in a normal vascular system. But over on this side, that web has loosened, and so chemicals and fluids are leaking out. Some blood cells can go out, but mostly it's the plasma or the watery aspect of blood. What's happening in the respiratory system, the other really dangerous system of the two, so the cardiovascular and the respiratory systems are the areas where we're most focused on danger. In the respiratory system, you start with a normal airway, nice open tube. The airway muscles are relaxed, and then in an asthma airway, or what's happening in anaphylaxis is severe asthma. There's tightening of the muscles. There's swelling of the soft tissue, which you can see on the outer aspect of this airway, and then you can also see on the inner aspect. And there's a pretty quick response of mucus production as well. Definitely, in chronic asthma, mucus is a major player, but even in the short term, mucus becomes a factor. We're looking here at small airways, and I wanted to also make a point about large airways. So more of the throat swelling that is so often referred to when people think of anaphylaxis. What's happening there is that leaking is occurring in a tight space. The leaking that's coming from the blood vessels is filling the soft tissue, and we all know that the airway is not a large area. So this photograph depicts outer swelling of the mouth and lips, which is certainly an indicator that the same thing could be happening back in the oropharynx and in the pharyngeal space. Important to notice that while this is depicting outer and evidence of inner swelling, you don't always see the lip swelling. So looking at the child's or the person's face is not necessarily going to provide a yes or no answer about what's going on deeper in. And the idea of asking the child, especially if it's a child to speak to you, to assess that voice quality is a good way of considering whether the large airway is at risk. So small airways, an asthma type response, large airway choking or swelling, and then the cardiovascular system, leaky vessels, empty system, heart rate too fast. Those are the dangerous things that are happening in anaphylaxis. So this is a cute depiction of a not so cute body process, but it's showing again that anaphylaxis manifests in different ways, and it's indicating again what we thought about in terms of anaphylaxis as a spectrum disease. So epinephrine, what is epinephrine? How does it work, and when do I give it? Those are really all the things you need to think about where epinephrine is concerned. And this I know you know quite well. There are different forms that we use for auto-injectable epinephrine. The AviQ is the new version, which talks to you, and I hope everyone's had a chance to use a trainer, and perhaps you have some of those in your school. Probably the most common, at least until recently, is the EpiPen, and this is Adrenaclick, which you may be familiar with as well. So what's happening with epinephrine? As you know, epinephrine is adrenaline. Epinephrine is the more commonly used medical term, and it's sort of the more modern term, but I'm sure you've heard adrenaline many times as well. There are two components to epinephrine. It's both an alpha and a beta agonist. Alpha and beta referring to receptor types. And they have two different types of effect, or epi has an effect that's paradoxical because alpha and beta receptors are different themselves. But it's important to know that the alpha aspect is focused on how our blood vessels are functioning. So when the epi is injected, It meets those alpha receptors and leads to tightening of the blood vessels. So it stops that leaking process. And the reason it's important to stop instead of letting the leak out occur and then try to treat later is you want to keep the fluid or the plasma in the blood vessel. So that alpha mechanism is going to work to stop the leak, and then the beta loosens the airway. Albuterol itself is a refined aspect of epinephrine. And years ago, not even that many years ago, probably at least even 20 or 25 years ago, people were treated by EMS in transport and in the emergency department with epinephrine injections for asthma exacerbations. I know all of you are way too young to have ever experienced any of that, but now we have albuterol, which is epinephrine refined, taking out that beta aspect, and it's used as an inhaled treatment for asthma, as we know. So the alpha and the beta are at work. They actually do opposite things. One tightens and one loosens, but they both aspects are directed at life-saving intervention for anaphylaxis. So I've mentioned it, Dr. Hogan mentioned it, using epinephrine early is critical. If the leaking has occurred, you're not going to get that fluid back in the right place by using epinephrine. So you're down the path on the vessel leak. While it's true that the epinephrine could help loosen a tightened airway, we all know that it's better to prevent that tightening than try to turn it around. So this is the core of why giving epinephrine early is so important. In addition to giving the epi early, another nuance that is being emphasized more and more these days is focused on positioning the patient. It's important to keep the patient supine or as near supine as you can keep them, and also keep them relaxed and comfortable. So at least reclined, if not completely supine. And the reason for that is going back to the blood vessel leak and the fluid shift that occurs. If you have had to give epinephrine, you are really on the anaphylaxis spectrum. So there has been some leaking, you know that. You've given it to stop continued leaking. But because there's been that fluid shift, you want to control as much as you can about that cardiovascular system going forward. So if the system is empty or relatively empty when compared with normal, you don't want to challenge it by having the patient stand or sit or walk. And that is actually at the core of one of the reasons why EMS transport is so important. There's kind of a mantra: if you use epi, call 911 and transport. And that we should always remember that. That's true for a couple of reasons. One is, there are interventions that can be used during EMS transport. Traffic could be a problem if you're trying to transport in a private car. But one of the most important reasons that people don't realize often is the ability to keep the patient supine so that they're not ambulating and they're not sitting up, and you're not challenging that cardiovascular system that is already challenged by the leak that we talked about. So once you're at the emergency department, what do you do? This is a cute little girl with a nice lady and someone examining her, and it doesn't look like there's much distress. Well, you may have had this experience. You give an EpiPen to a kid who's looking sick in your office, the transport occurs, kid looks perfect when you get there. And there can be a process of minimizing the history at that point. You're telling the story of what happened. You know that this child has had an allergic reaction, possibly anaphylaxis, but you might be feeling like you're getting the brush off there. Well, the point here is come in with the history, or make sure the person who's going with the child during transport brings the proper history, talking about the symptom presentation and the response to the epi you gave. If all that's happening is an examination of a child who presents looking well, that's really less than half of the story. So it's important to make sure that whoever goes in transport is prepared to relay that story. So this slide is repeating what I just said. Another element of history that's important to know about is whether the child has a history of asthma and whether that asthma on an ongoing day-to-day basis is well controlled or not. So if you have a child with food allergy who comes in and needs epi, and they are someone you have an albuterol inhaler for in your cabinet but you've never used it, they do have a history of asthma, but it's well controlled because you haven't had to use it. If the kid instead is somebody who comes in for puffs 3 times a day, that's critical. Many deaths associated with food allergy have a history of poorly controlled asthma as part of that patient's background. Just reiterating, as part of the history as well, it's important for the person going with the child via EMS to have information about previous allergic reactions. While it's true that you can't predict what a new reaction is going to be like in severity or pattern, knowing that someone has had a severe reaction in the past is important information. Some people's history evolves so that they have fewer and more mild reactions, and other people's history does exactly the opposite. Each one gets worse. So the history is not there to predict what's going to happen today. It just simply gives that caregiver added information to know that this has happened before. And we wanted to show a video.
During an allergic reaction, the immune system responds to a normally harmless substance as if it were a threat. In some people, common foods such as milk, eggs, and peanuts can trigger such a reaction. So how does this work? If you have a food allergy, your immune system makes a type of antibody called immunoglobulin E, or IgE. This class of antibody binds to immune cells called mast cells and basophils that circulate throughout your body. When you are exposed to the food allergen, it attaches to the IgE antibodies. This binding signals the immune cells to release histamine and other chemicals that cause allergy symptoms, such as swelling of the lips, hives, and shortness of breath. Because mast cells and basophils rapidly release these chemicals, an allergic reaction typically occurs within 30 minutes after exposure. The most severe kind of reaction is called anaphylaxis, which can cause a sudden drop in blood pressure, trouble breathing, dizziness, and possibly death. People with food allergy and poorly controlled asthma are more susceptible to severe reactions. An anaphylactic episode must be treated with a hormone called epinephrine, which maintains blood pressure and opens up the airways. To deal with accidental exposure, people diagnosed with food allergy are prescribed a medical device called an autoinjector that delivers a single dose of epinephrine into the thigh muscle. Antihistamines alone are not an effective treatment for anaphylaxis. There is no cure for food allergy. The best way to manage the condition is to avoid the allergenic food, read food labels carefully, wash hands and household surfaces, and always carry an epinephrine autoinjector. If you are accidentally exposed to a food allergen, seek medical help immediately. The National Institute of Allergy and Infectious Diseases, or NIAID, conducts and supports research to better understand, prevent, and treat food allergy. In 2010, an expert panel sponsored by NIAID issued guidelines to assist healthcare professionals in diagnosing and managing the disease. These guidelines and a summary for patients, families, and caregivers can be found on the NIAID website.
You can access this by punching in the address, which I think is on your handout. It's a video done by NIAID that is a brief video, less than 2 minutes, but goes through what I talked about in terms of the cardiovascular and respiratory systems and what happens in anaphylaxis. So, 3 months from now, if you're thinking, I can't exactly remember, it's a good thing to use as a refresher, or certainly as you're training other staff or even working with parents who may need added information. It's a good resource. So this is a slide looking kind of at things from a bright point of view, which I always like. So good things happen in allergic reaction situations when symptoms are recognized early. And who knows the reasons why you want to recognize the symptoms early? What's the main reason why? So you can give epinephrine early. Good outcomes happen when you treat promptly, treat immediately, and then when you seek emergency care immediately and go forth with transport. The story is really not over in allergic reaction until at least 4 hours later. Just because you recognized it is one thing, then you give the epinephrine, then you transport with proper information. And then, of course, in the future, once 3 days pass or the next day comes and the kid's back at school, you're still focusing on how can we prevent this in the future. I'm going to skip that one. I'm going to transition real quickly to a few food label points, and then I'll ask Dr. Hogan to come back up and we'll go through the questions that summarize what we've covered and hopefully will help you frame up the key points to take home. So you may be involved at times with screening foods to be used in the classroom, or you may find that parents are asking you, or certainly teachers are asking you for help in understanding what's okay and what's not okay. A couple of important things to note about food labels and claims about foods that may or may not be appropriate for people with food allergy. First of all, the term allergen-free is really out of vogue. It's not accepted. And the reason for that is it's way too broad. Any food protein could be an allergen for someone. So just because a food is without the 8 major food allergens doesn't mean that it's free of allergen for everyone. So we don't use that term. The other reason we don't is that even for the 8 major food allergens, the peanut, tree nut, fish, shellfish, milk, egg, wheat, and soy that we talked about, even in that case, we can't label anything free because there have not been agreed upon thresholds to define what free means. You hear the term gluten-free, and that is an accepted term because there is a definition of what that means. In Canada, it's already part of regulation that's been in place for about 20 years. In August of this year, FDA will put into effect a U.S. regulation with the same definition. It means less than 20 parts per million gluten. Again, for the allergens on that 8 major list, we don't have those thresholds defined. Chances are, at some point in the next decade or so, we may have definitions of what true peanut-free means or what milk-free means, but for now, that doesn't exist. Also on food labels, you'll notice there sometimes are warnings saying that a food may contain an allergen, even though you don't see it on the ingredient list. When those warnings are there, current advice is that you heat it as if the allergen is present. The language is very confusing because it's not telling you it is there, it's not telling you it isn't. It says it may be there. There have been a couple studies looking at this issue. Let's see. I'll come back to that because it's too cute to miss. So a couple of studies looking at may contain language and then testing the food products within the package. Enough turned out to be positive for the allergens warned against to lead to the conclusion that warning labels should be considered a true warning and those products should be avoided. Specifically, a particularly large study that was done in 2010 looked at milk, egg, and peanut, and of products that had an advisory label. For example, with regard to peanut, 4.5% of those products did have detectable levels of peanut. 10.2% of the ones that warned against milk did have milk protein. And overall, for allergens, 5.3% of the items had detectable levels. They also looked at foods that did not have a warning label and found that none of those had detectable peanut. 3% had milk that was undeclared, so milk wasn't in the ingredient deck, but it was found upon allergen testing. and that overall, for the allergens they were studying, the milk, egg, or peanut, 1.9% of foods without a warning did contain contamination. This is the basis for people like me who call food manufacturers to clarify, to get beyond what's the information that's available on the label. I do this a lot of times with candies in particular, because candy manufacturers tend to be small. They tend to shift to co-packers, so you're not really sure where the product was made, to always find out, is there a risk in the production environment for this particular food, whether or not there's a warning label. So let's see, I'm going to go back. So what I've talked about, where this may contain language exists, and clearly there's risk for contamination in the food production environment, brings up the fact that with regard to food allergies, there are two approaches to food manufacturing. The typical terminology talks about a dedicated facility or a shared facility and equipment. At Lucy's, we have a dedicated plant, so our products are made without wheat or gluten, without milk, eggs, peanuts, or tree nuts, and we never allow those ingredients in our facility. Whereas where there's shared equipment or facility, there might be, a candy bar or cereal or cookies or whatever it might be, made in a plant that produces things with milk and peanuts in one room and then produces things without in another room. What's happening in that situation is there is a potential risk that the wrong ingredient gets into one room or the other, or that contamination moves from one place to the other, either through air conditioning or on clothing that staff wear from one room to the next. So the point is that dedicated facility provides more safety, where the other situations are a situation that includes greater risk. If you follow or happen to have ever been aware of food recalls for what they call undeclared allergens, meaning it's not listed on the ingredient deck, those really almost always come from a production environment where there's either shared equipment or just simply a shared space. It all comes down to human error. Somebody put the wrong thing in the wrong place. So in summary, as Dr. Hogan mentioned, management of food allergy is focused on strict elimination. Education is key for families who are managing allergy on a day-to-day basis, and certainly within our school settings, so that we understand how to prevent food allergy reaction, and then, of course, having in place the proper emergency action plan is very important. So, Dr. Hogan, would you join me? So together we can go through the check your knowledge questions.
Clap along if you feel like a room without a roof. No, sorry.
Okay.
For another day, right? It's all, the happy song. Sorry, I was waking everybody up.
Very happy.
Always happy. So this is our little quiz, and when you pass this quiz mentally and you've got it covered, then we're going to go have a little coffee and cookies. So I know you all are enthusiastic about the coffee and cookie part, so you're going to want to get these questions correct. So the first question is all food allergy the same?
No.
Good. Because there are some other subtypes we talked about, specifically oral allergy syndrome and eosinophilic esophagitis too.
And I would say also that even within food allergy, is everyone's reaction the same? No.
If a child has only mild hives before when exposed, could this reaction worsen the next time that he has a reaction or later in life?
Yes.
Perfect. What is the term for a severe allergic reaction?
Anaphylaxis.
Dead on it. Good. And my little phonetic help. No, probably you all already knew it anyway. Sorry. What life-threatening allergy body parts, what life-threatening body changes happen in a severe allergic reaction? What are the two main systems we worry about?
And in the respiratory system, point to the two areas where problems could happen. and then more in the lung bases.
Make a dance out of this, the anaphylaxis dance.
Yeah.
What is the most important treatment for a severe reaction? We're going to spend a lot more time on that too, don't worry. When should I give the treatment? Early, and in general when there's two systems happening, or clearly if their throat is closing, I don't need you to wait and count for hives. That wins for me. How do you position a patient while waiting for EMS?
That's fine.
And do I have to call EMS?
Yes.
Oh. And let me just tell you a 20-second story from my nurses in Virginia Beach.
And then I have something else I want to tell you.
So I had a couple of nurses that said they gave epinephrine, and then when the EMS got there, they gave them a lot of crap and said, this kid looks really good, and, made them feel very wrong about it. And I found out about it, and I went to bat for them because, and if that happens to you at all, I personally want you all to email me, and I will get in touch with the people that we need to, EMTs that we need to re-educate, because you are front line. And if you're worried and you see it and you treat it, applause, okay? And no one is going to come down on you for treating it. We're going to support you, and if I need to re-educate the whole world, I'll try to do it. And that's why our new allergy action plan that we've had in place for a year doesn't even make it an option. It's an automatic. If it's my order and it's signed and you give epinephrine, it's a transport, period. Okay? And if you're not backed up on that, please let me know.
So I have another little update to share. I'm going to be leaving, so I wanted to tell you this now. And it's sort of a prelude into the next section of the presentations tonight. You may be aware of and confused by whether or not legally you can train non-licensed people in your school to administer epinephrine. So basically, is it okay to train the teacher in the classroom who keeps an EpiPen on hand and can use it quickly? Or can you send a class on a field trip without sending a nurse or someone who's MAT trained? There have been a couple of legislative attempts over the past several years to make that okay in both public and private schools. Based on some conversation and research I've done recently, it looks like there's a little gap that needs to be closed with regard to training unlicensed personnel in a private or independent school setting. The good news is I think that can be closed within the next few months. I talked to someone today at the Board of Nursing. They think we can quickly, through a process with the board, get that cleared up. The best case scenario would be that at the Board of Nursing's meeting on July 15th, we could get this wrapped up. And the worst case scenario would be that for some reason it's delayed and we go again on September 15th. My hope is that we can do it by this first round so it's clear when school starts again for you. I know we have all of your email addresses, and what I'll say is that we'll update you in July as to whether this has been cleared and closed up or whether we still have a little bit of work to do. But I know that's a concern for a lot of people, and there's been a resurgence of questions about it. We thought that in 2013 it was all cleared up by the legislative process in and of itself, but there was one little piece that said you can do it, but you have to get a protocol approved by the Board of Nursing, and that's the part that we're trying to wrap up.